I'm now going to introduce the theme of the third day, which has been woven in actually in our conversations and also in your experiences in the previous two. And the focus of today is this issue of technology. Smallish word, biggish concept, and very complex again. What we want to do is sort of unpack it, put it back together and see what we can do with it, and most importantly, how we can actually use it to improve what we do and to inform what we do in ways that actually genuinely value add, rather than just make us look good because we've got the right numbers on our data sheets. So to sort of walk us into this space this morning, we have our first keynote speaker for the day, who's actually Professor Keith McNeil. Now, Keith is the Assistant Deputy Director and Chief Clinical Information Officer, Clinical Excellence Division of Queensland Health. And Keith's actually going to take us on a little bit of a walk and talk through some of the opportunities and potential constraints of this thing we call technology. Keith.
Well, look, thank you very much, and it's great to be here talking to you. Can I acknowledge the traditional owners of the land? And in particular, when I say that, I think from a health point of view, we need to acknowledge that we've got a lot of work to do to try and bridge the gap between the health outcomes that are experienced by Indigenous people versus the non-Indigenous. And in fact, technology is one of the ways, probably the only way, that we're really going to make a significant dent in that. It's really great to have seen that video. What do they say in Hollywood? Never try and follow children or animals. And so now I've got to talk to you about data after listening to the Blues Brothers. But anyway, let's see how we go. So I'm going to focus on data and the opportunities that it presents us and how we might start to realise some of those opportunities at a system level. So I'm not going to talk to you too much about the intricacies of technology, but more about the systemic, the strategic sort of thoughts about how we can use data in our everyday lives to improve patient outcomes. So data everywhere, but not a bit to think, and we'll get into that. Just a couple of factoids, if you like, about data, things that you may or may not know. So the information bit, as you probably all know, was conceived in 1948, which is the same year that the NHS, interestingly, was started, by a chap called Claude Shannon at Bell Laboratories, and he used a branch of mathematics called information entropy to conceive the bit, and that's the same mathematics that's the basis of Scrabble letter scores. So there's a little trivia for you to take to your next pub quiz. 100,000 whole genome sequences are being done in the UK, and Australia's now set out our stall to sequence 200,000 whole genome sequences for people with cancer and rare diseases and whatnot, to take the genomic revolution forward. Well, 100,000 whole genome sequences will generate 21 petabytes of data. And to give you a frame of reference, 1 petabyte of music played on your MP3 player continuously will take you 2,000 years to get through. So you can see the size of the data sets that we're starting to accumulate, not only in health, but across the rest of science and humanity. And it's estimated that by 2025, human beings will have generated 47 zettabytes of data. And for those clearly who need to get out more, who have calculated what that means, that is supposedly more bits of information than there are atoms in the universe. So suffice it to say that our capacity to generate data is unprecedented as we move forward, and we have to find a way to be able to cognitively cope with that huge data load. Now, in health, in medicine in particular, we've always collected data. So here's something from ancient Mesopotamia where a clinician, a physician in this instance, is sitting down with a patient exchanging information. So asking questions, giving answers, and collecting that information to make a decision. I don't know if that's actually from Mesopotamia, but I bet you all believed it was, because I'm a so-called expert and you wouldn't have questioned it. So all throughout history we've done this. We've collected this at that clinician-patient interface. We've collected and aggregated data. And we've used it very wisely. We are where we are today because we've done that. So people like William Osler, who recognised patterns of disease presentation that we were able to then interpret into our condition. First person who turned up with crushing central chest pain and left arm radiating to the left arm didn't know they were having a heart attack. But when you started to see the patterns of people presenting like that more and more and joining it all up, you could see what the outcome was. Alexander Fleming, in his observations giving us penicillin. Louis Pasteur and microbes, Marie Curie and X-rays, where would we be without those? And Semmelweis and his observations about hand washing and the prevention of puerperal sepsis. So we've always gathered data and used it wisely. The birth of public health was all about data. So William Farr, back in the 1850s, was the inventor of births, deaths and marriage registries in the UK. And he used to meticulously, he and his clerks would record all of those by longhand in a register. And then in 1853, during the big cholera epidemic in East London, John Snow took that data. William Farr had analysed or recorded all of the cases of cholera in East London. And John Snow took that data and he analysed it, and he deduced that the cause of the epidemic was in fact a dirty nappy at the bottom of the well on Broad Street. Taking the handle off the pump meant that the water wasn't distributed, and that was really the birth of modern public health, all based on data, aggregation and analysis. In the digital world, we've gone from this. So here in 1897, the first fundamental particle of physics, the electron, was discovered by J.J. Thomson at the Cavendish Laboratory in Cambridge. And I had the extraordinary privilege of living exactly 1 mile from that plaque for the last 5 years, and it was a reminder to me every time I walked past it of the contribution of that. That was the first fundamental particle and is, of course, absolutely integral to everything that we do in terms of sending electronic messages around and collecting data. Very curiously, J.J. Thomson, as an aside, another little factoid for you, he won the Nobel Prize in 1906 for that discovery, the first particle, the electron as a particle. 30 years later, or thereabouts, his son won a Nobel Prize for actually showing that the electron was a wave, not a particle, and both of them are right, and that's the crazy thing about quantum mechanics. The chap up in the top corner there, Tim Berners-Lee, of course, we all know because he's the father of the World Wide Web when he was working in CERN. And of course, we can't share data effectively around now without that sort of technology. And it's very curious that when you talk to Tim about what he did in that space, that his supervisor called the whole project, the whole World Wide Web project, vague but exciting. That was the comment on it. Yeah, vague but exciting indeed. And of course, the fax machine is still used in healthcare today. So that's where we're going from, and this is where we are now in our lives. Our whole lives are pervaded by this digital technology, which has transformed the way we interact with our banks, the way we order travel or book planes, etc., etc. Even the way we pay for our cappuccinos out there in the cafe. It's everywhere, and we need to embrace this in health. Because we've also done this. We've accumulated data in ever-increasing amounts, but it looks like this. It's a big dump full of bits of information that don't look the same, that don't join up, that don't talk to each other, and I would defy you to go in and find what you want out of that data dump. And that's our challenge, is how we now take that data and give it relevance and purpose so we can make really good decisions and be informed the way forward. Now, of course, what this has led us to, this use of data, is a really good news story. And everywhere around the world you go, any society, you will see graphs like this, which show increasing life expectancy. Fantastic. So when the NHS was born in 1948, the average life expectancy of a male was 63 years, just over 63 years. Now it's over 83 years. And the same pattern is repeated all around the world. So a really good news story. But of course, there's a sting in the tail for us in healthcare, in that as those people age, as more and more of them age and get into the later years of their life, when they come to need healthcare, they deserve more services. And so they cost more, they're more expensive to look after at the standards that we set. And of course, that's added challenges for healthcare systems, which are lifestyle-related diseases, which of course bring that whole thing back into younger populations, who then require increasing input from the health system to enable us to provide good outcomes. So we have some significant challenges brought about by the fantastic things that data has enabled up until this point in time in terms of our ability to provide medicine, really good medicine and outcomes, and public health. And this is how we've done it to date. You know, we've gathered data and we've written it down on files, and we've stuck those files, locked it away in the basement of a hospital somewhere. Now that's all very well and good, but it's a bit like the crude oil analogy. So it said data's like crude oil. It's very valuable. You can store it, you can trade it on Wall Street, and you can sell barrels of it, but you can't do anything with it until you refine it. It's useless. You can't put it in your car, you can't put it in an aeroplane, you can't use it to heat your home until you refine it. And so data is the same. Data in and of itself can't do anything until we analyse it, and that's the refinement that we need to do. And we've got to find really savvy ways of how we can extract information out of that data. Because when you lock information away in the basement of a hospital, this is what happens. So on average, every year across the NHS, the National Health Service, 8 people on average a year die from being given penicillin and having that reaction when they've got a known penicillin allergy. So 8 people on average a year with a known penicillin allergy are given penicillin and they die. Now, nobody got up in the morning with the intention of doing that. The sole reason that happened is because at the point of clinical decision making, either prescribing or dispensing, the people involved didn't have the right information to make the proper or a better decision. That's what happens when you lock information away in paper charts in the bottom of hospitals or lose them in the back of doctors' cars. We've got to unlock that information so that everybody at every level of every organisation can make better decisions. And when you unlock data, you start to get what is actionable intelligence. This is one example from the Princess Alexandra Hospital just down the road here. I won't go through it in detail. It's a diabetes dashboard. So you can look across a hospital in real time and see everybody who's got diabetes. You can tell what their blood sugars are. You can tell who are the ones you need to go and action first if they're running into trouble. We can look at our 10 national safety and quality standards. This is data extracted out of the back of an electronic medical record, and we can update this in real time for individuals, for wards, or for the hospital as a whole, or the health system as a whole. We can start to get really actionable intelligence out of the data if we analyse it properly. And we can deliver benefits. We can deliver benefits to patients where we reduce hospital-acquired infections, we reduce their hospital stay, they get better outcomes, and we make the system work more efficiently, more productively, and so we embed sustainability when we unlock the power of data and information. But this is not about technology. I'll come back to this again and again. This is all for the sole purpose of improving the care we deliver every day to the patients in our hospitals, GP surgeries, etc. And deliver the triple aim, which of course you know is getting better patient outcomes, providing a better experience, and doing it in an affordable manner. And if you add in healthier populations there, then you get to the quadruple aim. And in my simple way, if we can do that, we can start to say to the taxpayer, to patients, to society, that we're providing value in healthcare. And data enables us to understand chaos. Now, we work in a system that, by definition, mathematically, is complex and chaotic. This is a cartoon that the King's Fund did of the NHS some years ago, and it shows you the kind of mess that system has been in. Having worked there for 5 years, I can attest to that. That's where clinical services are delivered, and the rest of it is a sort of a mess on top of it to try and make it all work. Now, one of the reasons it's got like that is because we don't understand the system, and we don't understand the system because we don't have the information necessary to be able to do that. But when you have the right information, you can actually bring order to chaos because you reduce uncertainty with data, right? Chaos only appears random and unpredictable because we don't have the right level of data to be able to understand it, to be able to interpret all the variables involved. And believe me, healthcare is very complex and we can't do that without technology. Now let me give you an example, ventricular fibrillation. So when I was a young doctor in training, we used to see people having heart attacks and they would go into the rhythm there, which is just a mess of lines on an ECG, and we just thought it was kind of random electrical discharges that caused people to die if we didn't fix it. What we now know, however, is that we can analyse the electrical vectors in that ECG down to 1/100th of a microsecond. So that's what technology enables us to do. Gather information at 1/100th of a microsecond. And when you do that and you apply the right algorithms, you can see patterns in how that plays out, and you can actually model what will happen in the future. Now that's an example of where we think something is random and chaotic, but when we have the right level of information and data, we can start to understand it and we can start to do something about it. And the same is true even if you take it at a big system level, like a health system. So we need to reimagine healthcare, and I noticed the banner outside from Nevada saying they are reimagining healthcare. Reimagine, where did that word come from? Well, it came from a guy called Eric Brynjolfsson from MIT. And he talked about digital transformation across any industry, and he said a couple of things, but one of them was that, you know what, you turn a switch on, you don't get immediate benefits. You've got to go through a few cycles of change to start to unlock the benefits, or what he called the productivity paradox. And the two keys were, first of all, you've got to have the right technology. Well, we're there now. We've got the technology to enable us to do this. And you've got to reimagine the work itself. So we don't want to use technology and just digitise, if you like, an old way of working. We've got to do both. And you've got to run through those circles 3 to 5 times, and curiously it takes about 3 to 5 years to really start to get the benefits out of it. So that reimagining the work, changing the work pattern to help to take advantage of the technology, and then changing the technology to help you reimagine the work is a really important paradigm. Leadership in the digital age, all of us here, is going to be critical because information flow starts to challenge normal corporate hierarchies, starts to challenge the linear dynamics that we normally apply in health systems. We start to look at platform models, which we know very well. Google, Airbnb, Uber, they're all platform models. They take information from someone who's got it and they present it to someone who wants that information. And that's in fact where we're going in healthcare. And what that'll mean is that we distribute decision making because we're able to provide information to the points of decision making so that everybody, wherever they are, can make effective decisions. Less reliance on contracts and central enforcement, which can only be a good thing. This sort of command and control hierarchy is not fit for purpose in the modern digital age. And for any of you out there who are command and control freaks, any of you there in corporate hierarchies, you know, be on notice. The information revolution will disrupt this. It is not fit for purpose, it doesn't work, and it stifles innovation. So what's the strategy? Well, simply, this is what we need to do. We need to structure and standardise the way we record data and the way we capture it. We need to capture it in innovative ways. We need to embrace the wearables, the apps, the Fitbits, the Bluetooth and wireless technology. We need to be able to spread data across the system with properly architected systems that enable information to flow from wherever it is to wherever it needs to get in close to real time. We critically need to be able to analyse data at every level in the organisation. And we need to be able to apply it at every level. And we need to do that in real time, not wait 3 to 6 to 12 months to get something that look back in the rear vision mirror. We need to move from what are called descriptive analytics to predictive and prescriptive analytics. And we need to find a way of really and tangibly engaging patients in their health journey, because we know when we do so, they get better outcomes and it costs the system less, so why wouldn't we do it? And sharing information, health information, and having them interact with that is one very powerful way of doing so. Shift the focus to the right place. Just have a simple paradigm, because it is a very complex environment. And these are 5 pillars that we developed in the NHS. Empower the person, that's engaging the citizen and the patient. Support clinicians to provide really good care wherever they provide it. Integrate the systems so that we don't have all these silos, so we can break them down so patients can flow across those. Manage the system effectively, so we embed affordability, sustainability, productivity, and importantly, create a platform for us to recognise and be able to recognise the opportunities of what's coming around genomics and the other omics, around artificial intelligence and machine learning. We need the platform, the data platform, to enable us to really grasp that opportunity. And underpin all that with modern cybersecurity, data access, governance, patient identity, etc., etc. But make it relevant to the people who are receiving care and those who are delivering care. Otherwise, it won't work. The EMR is electronic medical record is an absolutely key part of this. This won't happen without us being able to capture data electronically, digitally, and aggregate it up. And it's not just a fad. It is here to stay in one way, shape or form. We've got to embrace that. We move towards this, a learning and knowledge-based system where Every interaction between a clinician and a patient, I don't know how many it occurs across your health systems or in Australia, but in the NHS there's over 1 million every 36 hours. Every one of those interactions, we've got to capture data, we've got to aggregate it, analyse it, and then turn it into intelligence that can be used in multiple ways. So we move towards a single source of the truth for direct patient care, for public health and for business intelligence, and importantly for research. It's the same data set presented in different formats. And then you move towards precision medicine when you start to add in the machine learning algorithms, the artificial intelligence, bring in the genomics, the diagnosis that's coming, you bring in the apps and wearables, etc., etc. And as we move more and more towards precision medicine, we'll start to embed sustainability in the health system. Where are we now? Well, perhaps it's a bit like this. So this is the famous sketch that Frank Gehry did when he was conceiving the Guggenheim Museum in Bilbao. He did this on the back of a napkin. You know, it's a kind of vague resemblance, and it looks a pretty good idea of what we want it to be. Where we want to go, of course, is to get to the finished article, if we ever will. A learning and knowledge-based organisation at all levels, at the cutting edge of digital medicine, where every individual can use the data available to them to drive their own performance in real time on a daily basis, where we can really share learning and benefits across the system for an effective flow of information, and when we can embed sustainability and enhanced effectiveness. Really important. So we're going from this data dump, data everywhere, but not a bit to think, very difficult to use. We're moving in very rapidly to a situation where data everywhere with lots and lots to think. And I'll leave you with the thought that there are only 10 types of people in the world, those who understand binary and those who don't. Thank you.